Now, this slide, when you're looking at your notes, this slide and the slide right below it are essentially saying the same thing in two different ways. The next slide that you're going to see is a graphic analysis. This is more of a table approach. If you look at the top half, those first 5 are all secondary preventions. Again, when primary is to avoid the disease itself, secondary prevention is avoiding complications once you have a disease. So you see the 4S trial has a relative risk reduction by adding simvastatin of 50%. So that seems really huge. That doesn't mean that simvastatin is better than the others, okay? That when you go to this next slide, there we go. Okay. There's the 4S way up at the top. That was dealing with people who already had severe coronary disease. 4S is the Scandinavian simvastatin survivability study, okay? So hence the 4S. So they had the biggest risk reduction in part because they took some of the seriously ill patients, all right? So there's really not a whole lot that says one statin is better than another under any circumstance. But simvastatin was used in that case. Then you have the WOSCOPs over here on the right. That's the West of Scotland Coronary Prevention Study, in part because it's done in Canada, which is west of Scotland. So they focus on people that are actually pretty healthy. So they're putting people on pravastatin in that case, and you're seeing a risk reduction, although less robust. As you move left on the LDL curve, you get a slight drop in the percentage of cardiovascular disease events with that. I feel kind of like a weatherman doing this. But so you get a drop, but the point is all these different studies are funneling down. There's really no such thing as too low of a cholesterol, okay? But on the other hand, then you start getting back into the ACCORD stuff. So here we go again with the ACCORD. So they get put on simvastatin. They're going through all these different guidelines, followed over 8 years, and they get combined with fenofibrate or simvastatin, with the simvastatin, okay? So everybody's on a statin, but then some people get put on the fibric acid derivatives in addition to that. They're looking for outcomes by being more aggressive, and they don't see it, is the nutshell again. So there's no such thing as too low of a cholesterol, but again, you have the concept of a diminishing return, that at some point, the difference between an LDL of 60 and 55, these are extremely low bad cholesterol rates. The chances of really improving people's outcomes at that point are pretty null. But there is no such thing as too low of a cholesterol, all right? Statins improve survivability. Your patients, if they have coronary disease, should be on a statin no matter what, even if their cholesterol's fine. That much we're sure of, okay, even if it's a low dose. But the point is, if somebody's diabetic and they're on a statin and their LDL is 103, again, we're starting to get into kind of a gray area now because of the studies that how much more aggressive should we be? Do you bump it up and risk the rhabdo that comes with it or the myalgias or side effects? Do you add another agent to try and get 3 LDL points down? It's a little bit gray, grayer than it has been in the past. So we're still waiting to see when they break down all these patient groups whether or not they're going to change some of those guidelines. So then, talking about these dyslipidemias, you need to do a lipid profile every 1 to 2 years. Most people would say every 1 year. Primary goals, pretty much like we talked about, below 100. You have secondary goals with it. Statin usage for primary prevention, age 40 with one additional risk factor. The word additional we added because there were some points, well, wait a minute, diabetes is a risk factor, right? Yes. Diabetic patient, age 40 with an additional risk factor for clarity. That's someone that should be on a statin. That can include just blood pressure issues or otherwise. Secondary prevention, if they have overt cardiovascular disease, you need to put them on something no matter what. Reduce their LDL by an additional 30 to 40% from wherever they are, shooting for an ultimate goal of less than 70 in the highest risk individuals. So that's just a summarization of what we were talking about. For dyslipidemia, target the LDL first. There's a lot of cholesterol companies, if you guys allow drug reps to come in and talk, they're really pushing the idea of non-LDL or non-HDL cholesterol. That the LDL plus the triglycerides plus all these chylomicrons and so on and so forth, they're trying to focus on everything other than HDL. And that's all good, but LDL is the biggest risk. Then you focus on isolated low HDL. Things like niacin can improve that. That's statistically the best at raising your good cholesterol. Then low HDL and high triglycerides, you look at fibrates, combining a statin with fibrate. You have to be a little careful. We have a slide coming up talking about this on the interactions between the two, or adding a niacin. So you look at this, and in particular down there is cerevastatin. And if you have cerevastatin in your sample closets, you need to clean out your sample closets. Because what is that? Baycol. So it was recalled. So not on the market anymore. And the point is that when you combined it with things, especially gemfibrozil, you had way higher incidences of rhabdo and complications from the statin itself, looking at your peak concentration changes when you combine the two. The nice thing is when you use fenofibrate, you don't tend to have as much of an amplification of those effects in other statins. So most statins, when you combine it with fenofibrate, don't tend to have that risk, but you still have to watch for it. And then finally, antiplatelet therapy. ADA standards, this is kind of again waffling around a little bit. Aspirin therapy, typically 81 milligrams for both secondary and primary prevention. You use something, I was talking to Matt about this yesterday, about these Framingham risks. That if you have the calculators that decide, what someone's 10-year risk is over time based on their age and their blood pressure and so on, you can calculate it, and for the most part, it's only about a 10% risk in younger individuals. So they used to say, well, maybe everybody needs on aspirin, other than kids, because you don't want the Reye syndrome issue. So you used to say pretty much everyone needs on it. Now it's saying maybe after age 50 for men and after age 60 for women with an additional cardiac risk factor. Again, being anything from blood pressure to cholesterol or you name it. So if they're diabetic and have any other problems and they're a middle-aged adult, they need to be on aspirin. Again, the only reason why we're considering, well, why don't we just put people on it? If they're 30 and they're diabetic and they have high blood pressure, why don't you put them on it then? You can, but then you have the cumulative risks associated with the GI bleeding and the side effects of aspirin, that it's not a completely benign therapy. The lower the dose, the less likely you are to see that. So 81 milligrams, for the most part, has a pretty low incidence that I don't have any reservations about putting a 30-year-old on aspirin if they have the risk factors. And yeah, occasionally they're going to have a GI bleed, but the outcome prevention from that antiplatelet standards due to the prothrombotic, pro-inflammatory state of diabetes definitely has better outcomes in the long run. Then you talk about Plavix for the very high-risk diabetics or people with intolerance to aspirin. Usually that's people that have had a previous cardiovascular event and or surgery, but not always. There are people that just can't take aspirin due to allergies and then end up on Plavix purely for risk prevention.